All right, here we go. Well, hello, everyone, and welcome to the Heartland Daily Podcast, where today we're going to be talking about healthcare as we do a couple of times each month. My name is AnneMarie Schieber. I am the managing editor of Healthcare News, and joining me is Devon Herrick. He is a healthcare economist who writes for the Goodman Institute Health Blog, writes about a lot of topics. We have so much to talk about. I think since the last time we met about 3 weeks ago, so much has been happening on Capitol Hill, which we'll get to in a minute. Later on, we're going to talk about just a variety of issues, a great topic all the time, which is how to save money on prescription drugs. What happened to baby powder? This is something I thought was kind of funny, but there was a big change in the last year, if you haven't noticed. And how also is a good way to consider realistic risk. You know, if you read the media, our life is in jeopardy every second. And we can drive ourselves crazy, but it doesn't have to be that way. And there's a big article that came out a couple of weeks ago. Devon wrote about it, and we can talk a little bit more about that. But before we get to all that fun stuff, we need to talk about what's going on Capitol Hill, and especially the Big Beautiful Act, which turned out to be a big, beautiful disappointment to healthcare reformers, at least in the terms in the conversation regarding Medicaid. So Medicaid is a huge program, and it impacts all of us in one way or another. 1/4 of the country is enrolled in Medicaid, and it impacts how we deliver healthcare, the prices we pay for healthcare. It is a massive program, and a lot of people thought we had a golden opportunity to reform it, since the Republicans are controlling, one party is controlling the White House and both chambers in Congress, sort of like how it was in 2017 when we thought we were going to get a repeal of Obamacare and replace it, and it never happened. Again, very tight margins in both chambers, and the Republicans just kind of bailed. A couple of takeaways. So what happened? This bill is now in the hands of the Senate. It passed in the House last night by, I think, 1 or 2 votes. There were a couple of holdouts. 2 votes, I think, 2 Republicans. It was, I don't know, 2 votes it passed by, but it's now in the Senate. Who knows what could happen there? But many eyes, a lot of attention was focused on the Committee for Energy, which actually manages healthcare spending and Medicaid. And the idea was to cut $800 billion from Medicaid over the next 10 years. So in this bill, what we had was not a whole lot. We cut $700 billion over the next 10 years. And we got a work requirement in there for childish. Let's pop up, if we can, the Beckers did a really good take on Monday. So there are 5 things that happened in this bill, and all the big ideas about reforming Medicaid never happened. We got a lot of the same old stuff that we've had, which are good things, but just not really cutting edge reform. This new bill establishes work requirements for adults aged 19 to 64, and it doesn't even start until the end of next year. It's restricting states from these thing called provider taxes to fund Medicaid. So these are penalties that states purposely impose on, or taxes they impose on providers, and then reimburse these providers for that tax by billing the federal government. It's called a provider tax, and it's money laundering. It's kind of a racket to help states on their big spending plans. It has nothing to do with healthcare. They're going to end that. What else? They're going to shorten the ACA open enrollment period. I'm not sure what really is behind that. They're definitely going to impose penalties for covering unauthorized immigrants. That's kind of a no-brainer. And prohibiting the use of Medicaid and CHIP funds to pay for gender transition procedures for minors. Another no-brainer. But my goodness, we could have gotten to $800 billion. The problem is everybody is worried about the election in a year and a half. And Republicans are running a very tight margin in the House. And if they lose the House, we could have 2 more years of just paralysis, nothing getting done. So they were very much concerned. As I mentioned earlier, 1/4 of the country, about 1 in 5 people, is on Medicaid. So you have Republicans in districts that have massive Medicaid coverage, and they were not going to bail on this. And the Democrats were making hay out of cutting benefits, right? And they were winning the media war on this. But really what it was doing, what we needed to do was clean up the waste, fraud, and abuse. You could have gotten to 800,000, and you could have done this in a way that would have made the program more attractive to people that use it. And we didn't do that. So Devon, let's talk about some of these ideas. So a couple of weeks ago, I talked to Rep. Chip Roy, and this was before all of this unfolded. And he was just livid because he thought Republicans were really wimping out here. He said they are drunk on tax cuts and spending, but you cannot do both. And he was holding out. He was a holdout, I think, up until Friday of last week. He wasn't going to vote for this because in this bill, of course, is the big tax cut. And he was saying, look, we are not cutting money in Medicaid. And this thing is going to crush us. And we need to really get our hands on it. And this is our chance to do it. We put out, let's see, and if you could pop up that article that I had there in Healthcare News, you could read his comments. Yeah. All right. So in there are comments. I did like a half-hour interview with Rep. Roy, and he has some very harsh remarks about, the state of Capitol Hill and the politics. The other thing is I want to pop up another article. So John Goodman, who is the co-publisher of Healthcare News, that's the second article, if you could pop that one up, how to get $880 billion in savings from Medicaid benefits. Okay, this is a great article. He came up with, I think, 12 reform ideas that we could sell that would be very sellable. One of them, of course, is giving enrollees control over how they spend the money. Right now, it goes through a third party and it's wasted. It's misused. There's fraud. There's, all kinds of not good things. And if you give people their own spending accounts, sort of like they have for food stamps, they would probably spend it better. And we should be incentivizing people to use it more smartly than waste it. Now, Devon, you wrote something, if we could pop that up. There's a lot of non-Medicaid, non-medical stuff in Medicaid. If you could pop that article up, there we go. No, not that one, the one before that from the Goodman Health Blog, that one. Okay, so Devon, why don't you tell us about this and this spending in Medicaid that has nothing to do with healthcare?
I think the article, that's actually another article we pulled up. The one
sorry. All right. Let's.
It's the one is non-medical spending, just welfare expansion. I wrote it on the 20th.
There it is.
And, yeah, exactly. And here's the thing, and just to kind of step back for a second, you were talking about John Goodman's 12 points. Well, number 12 is the one that we should really, that is absent, like noticeably absent. It's give a Medicaid block grant. And that I say that because that would let states do exactly what I'm writing about in this article. Essentially, there is what is sometimes called the social determinants of health.
Oh, yeah.
We know that poor people tend to be in worse health than richer people. We know that educated people are in better health than less educated people. So a lot of states, and especially the public health advocates, say, hey, can we please spend Medicaid money on things like housing or things like, counseling, things that technically aren't really healthcare, meals on wheels. And it's not a bad idea. It's just that there's no checks and balances. I mean, what the argument runs that we can spend money on some things that are not related to healthcare and actually save Medicaid money. Okay, if that's true, a block grant would let you spend it in any way you want to spend it, to get the desired results. If you're wrong, you pay the price. The states would pay the price. If you're right, you could be more efficient, provide better services. But basically, during the first Trump administration, they allowed North Carolina to experiment with housing and a variety of non-medical services with the idea that that would improve the health of some Medicaid enrollees. Well, now, during the second Trump administration, HHS, Health and Human Services, is saying, we're going to kind of cut back on that. We're not satisfied that that actually worked the way we hoped it would. Well, I don't doubt that there are ways of saving money by spending money on saving Medicaid money, I should say, by spending it on things that would prevent, for example, emergency room visits. That's where a lot of money is wasted.
Yeah.
Some people ended up go to the ER and get admitted to the hospital for reasons other than, basically because they didn't have follow-up care for maybe a hospital stay. So yeah, there are things that you could do that would probably save Medicaid money in the long run. But how do we know? And this is kind of how I conclude my article. Is the problem is whenever states experiment, they're not really bearing the risk. They're just trying to get, in many cases, I think, just trying to get more money for more services that are really welfare services as opposed to healthcare services. And, a block grant would allow that to, the states to experiment.
And when you're getting a bunch of money in through the avenue of healthcare, you can spend it on things that maybe have nothing to do with healthcare, like green energy and all this other spending that maybe state taxpayers don't want or maybe want, whatever. But we're getting extra money. It's just another way of federal filtering more federal money to states. And the thing of it is, the beauty of a block grant is it allows states to value Medicaid. So let me just read this, because the Democrats have been having a heyday on this issue, and the public doesn't understand it. And this is why the Republicans were so afraid. They are not making the right arguments. They are seen always on the defense as cutting benefits. And even if you're trying to get rid of waste, the Democrats attack them for going after benefits and leaving people on the streets, which is not the case. I mean, here's one quote I found from a Democrat, and it goes like this: cutting Medicaid doesn't save money in the long run. When federal funding drops, states must either cut services or raise taxes. That means fewer resources for schools, roads, and public safety, or higher costs for working families. Let's be clear, Medicaid is one of the most efficient programs we have. All right? So this is just total hogwash, right? I mean, it's if states value it, what the thing about states having control over this money and this budget is they've got to set priorities, spending priorities. And, you don't, if a healthcare, free healthcare or safety net healthcare program is important to your residents, you will make compromises on other state spending to cover it. But the way it is now, there is no guardrail on that. So I was really disappointed to see that there was not a block grant type of reform in this bill. All right. So that to me was like number one, wasted opportunity. I want to pull up another article because Michael Cannon at the Cato Institute, can we pull up the one from USA Today? Going back a little bit, it was the op-ed in USA Today. There it is. Okay. So Michael Cannon came out with this a couple of days ago, and he talked about how this is not true what the Democrats are saying. This program is going to bury us if we don't control it. We couldn't get to 800 billion, which was a conservative number, right? Over 10 years. We only got to 700 billion. And without these reforms, we are going to see more of this waste. Let me just read a little bit about what he said. He said, let's be honest, Republicans are not cutting Medicaid, but they should. If, as the Democrats fear, Republicans were to reduce future Medicaid spending $880 billion by 2035, the program's annual growth rate would merely fall from 4.5% to 3%. And that is nothing. This could trigger a debt crisis in 10 years. The thing about politicians, they may not be around in 10 years. It's future generations. And we do this over and over again.
Mm-hmm.
And then crisis mode, and we're going to have to make some hard choices in the future. We had a golden opportunity to fix this, and we blew it. Go read Goodman's 12 things. I mean, these are simple measures. The idea, I bet every Medicaid beneficiary would love to have a spending account and have some control over the doctor they go to, or how they could do their own social determinants for healthcare, right?
Mm-hmm.
If getting a ride to a doctor is an important thing for them, they could use their account to do that. But maybe they don't need, some other things that are thrown in there that, are just a total waste. Right now, it's all controlled. I'm sure there was heavy lobbying going on by the managed care industry and the hospital industry fighting all of these reforms, and we are going to pay for it. And it's just really too bad. I'm hopeful that maybe that we'll get a little bit better stuff in the Senate, but I'm not holding out much hope. So there we have it.
Well,
all right.
One of the most controversial aspects is the work requirement. I mean, why is that controversial? If you want to get an assistance and you're an able-bodied adult, of course you need to help yourself first before you ask for assistance. And that's being, tested in Georgia. And what they found is that a lot of people, I forget the exact figure now, only something like 4% of people that are eligible have gone that route. And it's because it's not worth it to them. I mean, it's just not worth enough to many of the people to even jump through a hoop to get free coverage. And that's an indication that you're probably wasting money.
They didn't value it. The ones who are benefiting from this are the managed care companies, because they're going to get their check, whether you like it or use it or not. And of course, that's where probably some of the heavy lobbying was coming. This is a cash cow for them. Mm-hmm. I mean, Medicaid, and the thing about Medicaid work requirement is this is not an end in itself. Medicaid is a safety net. It's not a healthcare system for you for a lifetime. And if you have to work, you'll probably get some job experience, maybe get a better job where you get better employer care and then you get off of Medicaid. I mean, there's so many numerous problems with Medicaid. Anybody in that program finds it's like nearly impossible to get good primary care. That's why they end up in the emergency rooms because, and they wait for hours. Think of all if they're hourly employees, the time that wastes, the money that they lose. It's just an expensive, foolish way to deliver health care. So we kind of figured out the problem again. The solutions, they just weren't chosen. So anyway, we missed a golden opportunity. All right, let's move on. So Devon, you wrote about a really good thing, if we can pop that up, about cutting prescription drug costs. There we go. Now, you've written about this topic a couple of times, and I read through this, and I shared this with family members because you hear about this all the time. I have, I have some ways of keeping my costs down, but let's talk about some of the things that you recommend here. There were some new things. Tell us about what's in your blog post here.
Well, in my blog post, I ran across an article on how to save money on prescription drugs, and I thought, wait a minute, I've written about that. Large studies, research reports, and so I looked at the article, and it was actually stealing my ideas, but they had a few of their own that, which is fine because that's why I do reports. But
right.
But anyway, some of the first thing, well, I should say, I mean, the article had a lot of the items like ask for larger quantities, buy in bulk, go generic. Well, the most important step was not even mentioned in the original article that I was quoting. I have to look and see let me see, which I found on MSN. It's the third link in the blog post. But the most important step to saving money on drugs is talk to your doctor. Your doctor is the only person who can authorize a prescription. Let your doctor know you are price sensitive. Let your doctor know, hey, because what happens is your doctor knows that you like free stuff. So your doctor goes to the medicine cabinet or the storage cabinet and pulls out a sample. Well, that sample is an expensive drug that drug makers are marketing. I mean, they go by the doctor's offices, the reps, drug reps, drop those off, and they are an expensive name brand drug. So, oh yeah, okay, great. Give me a free sample, but also let me try the cheap generic first before you give me a drug that in fact is not really a benefit, is actually a liability. It's an expensive, a name brand drug. A free sample is the most expensive drug that you can take. If that, and a lot of times people just they take it, it works, they refill it. Well, they never tried the cheap one. The cheap one may have worked too at a fraction of the price. And so that's the most important tip, is ask your doctor about a generic before you jump to the name brand expensive drug. And I also did some case studies over the years where, for example, oftentimes just pull a number out of my head here. Let's say a 100 milligram tablet may be about the same price as a 50 milligram tablet. Talk to your doctor and say, hey, can you prescribe the 100 milligram tablet and I cut it in half?
Yeah, you get one of those little pill cutters. That makes a lot of sense.
Exactly. And, I use them. I have one, I have a cuticle cutter that I use for my dog's medicine because they don't make the exact dose. I mean, it's very simple. And sometimes you can buy in bulk. When I say buy in bulk, for example, you go to Walmart. Walmart has their $4 per month generic prescriptions. Well, a 3-month supply is only $10. Okay, that's sometimes I've done case studies where you could save quite a bit of money by buying in quantity, buying double strength in quantity and splitting them. But let me look a few other things. Shop around. What was interesting is when I first began writing about this topic in 2006, I had dental surgery and I had to fill a prescription. And even though I was in pain, I thought, I really need to practice what I'm preaching. So I started calling around, and I, in fact, found that I could save quite a bit by going to one pharmacy versus another. But another good tip, use a prescription discount card. What's happened over the last few years is that pharmacy benefit managers, commonly called PBMs, have consolidated to the point that the 3 biggest now control 80% of the market. Back in the day, whenever a health plan member went to a pharmacy, that was a cost to their health plan. Nowadays, their health plan probably makes money on the deal, because what happens is their PBM is owned, 2 of the biggest PBMs are now owned by health insurers. And so they literally charge more for the cost sharing. Your copay is probably more than the drug itself cost. So you're filling a prescription, they're making money on it. Well, what a lot of experts have found is that if you use a good RX card, that's a discount card, that sometimes you can buy that drug for cash cheaper than your health plan discount. Mm-hmm. And that's, if you're trying to meet your deductible, okay, that might be an issue. But if you don't expect to meet your deductible, check and see if the cash price is cheaper than your copay.
I think these are really good tips. I have a couple of thoughts on this. So first of all, there is this belief by a lot of people that over-the-counter drugs are not as effective as prescription drugs. And we know that's not true. Look at, what happened during COVID. The most expensive treatments being pushed were ones that really sometimes were not only very, very expensive, but they weren't as effective. I remember, it was ivermectin and hydroxychloroquine that people were using that were not being promoted. I got COVID and my doctor gave me a prescription for a brand name inhaler that was $500. I would never get this product. I mean, it worked, but there were other things that I could do that were far, far less money. And so I think your point is well taken, that the drugs, that the free samples you get in the doctor's office are there for a reason. They're trying to get you hooked on very expensive drugs. And this is what PBMs do. You know, they do deals behind the scenes that you don't know about to get these very expensive products in their formularies, and at the expense of cheaper, better drugs. So you have to be really careful of that. The other thing is you need a good relationship with a primary care doctor, and that's hard to get today. That's why DP is so wonderful, because they have a model that allows you to spend time with your doctor, and he can get to know you. He can know your price sensitivity. He can find you alternatives. I mean, my doctor is amazing in finding me low-cost alternatives to drugs. There's an example of the drug Humira, which is super expensive for inflammation and arthritis. It's like at least $550 a month. I have a friend who went on this drug for 3 months and it didn't work. It spent all that money for no reason. And there are generic drugs that can also maybe do the same thing. All right. They're not the latest drugs, but why not give those a try? Right. And then I found with the GoodRx cards, they're a great way to compare prices, because you can go on the app and it'll tell you all the prices, everybody offering them. The idea that if you work at, I've had a lot of luck going to non-big chain pharmacies and getting to know the pharmacist, because sometimes there are other discount cards that they have that you don't have, and they can find the drug even cheaper than you can from like GoodRx or some of these other programs. So that, again, is another possibility. And then I've not done the online pharmacy thing. Maybe you have, Devon, but I found it to be a real pain. You got to fill out a lot of information. And then this is the thing. Oh, I want to say one thing about the RX cards. They can sometimes get you into usually a big chain at a very cheap price for your drug, but then it shoots right up in, month 2, month 3. And they know what a pain it is for you to switch that drug, that prescription, over to another pharmacy. So they've got you locked in there. So you got to be careful of those introductory prices.
The coupons, yes.
The online pharmacies, have you had any luck with those?
I have actually used online pharmacies. So there's 2 different types. There's mail order, which is your health insurer saying, if you're on a blood pressure drug that you take month after month after month, you need to switch that from CVS up the street to our mail order pharmacy that gives us a better price on it, and it will be shipped right to your home. The other type of mail order pharmacy is, is one where you go online, and it varies. In some cases, it's a local. It's a local pharmacy that may have a web presence. They may have a doctor on staff. Your doctor can send a script, or their doctor can send a script or authorize a script. I've used those before, and those can be handy. But then there are foreign pharmacies. I ordered a drug. It was a few months ago. It was a name brand drug ordered from, I think an Israeli pharmacy, and it was actually shipped out of London. It was not, it was just, drop shipped. It was a name brand, and it was maybe half the price of the name brand locally. So cheaper than the generic, actually. So
now, I'm surprised you were able to do that. I thought there were laws prohibiting the delivery of drugs from abroad into the country. Is that not the case?
Well, yes and no. There is a federal law, but there are also patients are allowed to, if it's just for personal use in small quantities. I don't know all the details of it, but if you try to order Valium, they're going to stop that. But I've literally, where they had them give me a tracking number that says, okay, it is now at the Newark Liberty or JFK, the imports, where they're supposed to be looking for that. And it's stuck there for a couple of days, then it arrives in the mail a few days later. So, you have certain states, I think Florida was one, Colorado was looking at it, actually trying to import drugs for their state health plan from Canada.
Yeah.
Well, we can't all buy from Canada, simply because they're not a big enough country to have enough drugs.
Yeah.
But, and I'm not saying the entire USA can go online and find something cheaper, but I've had pretty good luck at it over the years. And
and
a lot of seniors do it. A lot of seniors, that's their go-to. Canadian pharmacy is their go-to way to get drugs cheaper.
No, it's something like 80 to 90% of all drug sales are generic drugs, mostly low-cost drugs. We have a very robust generic drug market, as long as we preserve it, because if these companies do not make money and we cut their margins and regulate them to death, they are not going to make their products, and we won't have those products. So that's important to keep in mind. And then, those rules about drug imports are really made for mass importers. They don't want our market being flooded with these big, cheap drugs. First of all, there's a safety concern. So there's a reason for those rules. It's not to make Americans pay more. There's a good reason behind them. But I, again, think it's just smarter. Even if you have a very expensive drug, there's no guarantee it's going to be better for you. Everybody's different. Like I said, Humira is a very expensive drug. It works for a lot of people, but it doesn't work for everybody. And sometimes it just pays to be patient and try cheaper alternatives to get the result that you want.
Well, it's interesting. You talk about Humira. I wrote about Humira a while back. Humira is a biologic. It is it's for inflammation like rheumatoid arthritis, autoimmune disorders. Well, Humira finally, lost patent protection a couple of years ago.
5 years. Yeah.
And so, they extended their patent. They were able to for several years, but it finally lost patent protection. All the experts said, okay, this year they're going to lose market share to a lot of biosimilars, the closest thing we have to generic Humira.
Yeah.
They did. People like, what happened? How come they didn't lose market share? Because the manufacturer went to the PBMs and said, hey, if you switch all your clients to the cheaper ones, you're going to lose big rebates on not just Humira, but other drugs as well.
Yeah.
So guess what happened? They, the cost sharing for the cheaper drug, it was a third the price, was the same as Humira. So why switch?
Yeah.
And that needs to stop. That's double dealing.
Yeah. There was big hearing on Capitol Hill on biosimilars and the holdups in getting those drugs out of the market. Biosimilars can save maybe 50% of the cost of those very expensive drugs. And let me tell you, there's a war to keep them off the shelf. So I'll post a link to that article because it has a lot of information about, what's going on behind the scenes and what's taking place to get consumers to pay more for these drugs. All right. We are kind of running tight on time and we have 2 more topics to talk about. So I got to tell a funny story. The other day I was changing a diaper, my grandbaby, and I picked up this stuff. Okay. This is baby powder. And I sprinkle it on my hands. I don't make a big puff of powder, but this stuff felt like chalk. And I'm looking at it, and the thing is like nothing better than this stuff, cornstarch, right? This is what it is. And I went to the store to try to find a product that had talc, and I couldn't do it. All of them are made with cornstarch. So, Devon, I wrote to you about this, and you were very familiar with this subject. Now, here's the thing. I had to go on Amazon to find real talc. All right. I found it. It's like triple the price now. So let me tell you, this is cornstarch that has a scent, right? It's about double the price of this stuff. Okay. And then if you want to get talc, get ready to pay for it, because this is like double the price now of baby powder. And so, you can make your own little combination if, the price this is made in India. But, this cracks me up, because you found this article on the American Cancer Society's webpage. Why don't you talk about it? Can we pop that up? Yeah, there we go.
Part of the issue is that there has been a lot of, class action lawsuits. Any, woman who has cancer or like uterine cancer and the like is joined a class action lawsuit suing, I think, Johnson & Johnson and other companies that sell baby or have sold baby powder, claiming that, well, they got cancer due to talc. Well, that's doesn't make a lot of sense to me. It's, it's a topical powder. How are you going to get cancer from that? I don't know, but nonetheless, a lot of lawyers have been able to win big awards. And so literally, I don't think any U.S. company would sell talc anymore, simply because they're afraid of getting sued.
Yeah.
And
the thing is, there's a belief that asbestos is in natural talc, but the percentage, according to this Cancer Society article, it's so minuscule that it really isn't going to make much of a difference. And people don't use it in large quantities. They don't create powder clouds. Like that was always the thing with babies. You didn't want them inhaling the talc or whatever. But I don't know anybody who does this on a baby, or if they have to use powder, makes that kind of a mess that you would breathe in clouds of this stuff. But again, this is really too bad, because I'm not buying this again. This is not a useful product to me. So, I wrote about a couple of months ago an article. I don't have it here, but in January, I wrote a commentary called Shakedown Lawsuits, Not Safety, Explain Drug Shortages. And what this was about, we had been tipped off that in Connecticut, I think it was Senator Blumenthal, he asked the FDA to investigate and recall acne products containing benzene. And what he was trying to do is push work to a lab in his state. And what this lab would do is they would put these products under extreme conditions and then come out and say it produced some kind of carcinogen. And then they would go after the manufacturers to either settle a lawsuit. They create these class action lawsuits. It was all a money-making operation. And this is what happens, with things like talc. You also mentioned Roundup. That's another example. Tell us about that.
Well, yeah, Roundup, I come from a farm. My late father was a farmer. And Roundup is the most widely used herbicide. It is the safest herbicide. It's essentially a salt, a type of salt. Compared to some of the older herbicide, it was, a godsend. It worked well for many, many years, and it was far safer than anything on the market. Well, over the years, lawyers have gone after Monsanto and other makers of the generic. It's now off patent. And so they're winning large awards. And in many cases, really, it's just my opinion that a jury feels sorry for someone who has, often it's some type of cancer. And of course, lawyers are very good at making convincing arguments. And oftentimes it's little more than a jury that has a soft heart that thinks this poor man has cancer. Someone needs to help him. Oh, we can help him. We can give him $1 million, $2 million. Well,
right.
That happens enough times, that product goes off the market, and it's regulation through litigation is not a good idea. I know we need litigation sometimes, but nonetheless, it's like talc. Is talc really responsible for uterine cancer? No. Right. Is Roundup really responsible? No.
Right. And most people don't understand the difference between correlation and causation. Most of these are correlation, and they don't impact everybody the same way. Cancer is huge, it's widespread. The human body is a complicated machine, and humans are constantly exposed to countless risk factors, products. Carcinogens abound, right? But not everyone gets cancer. So, when we come down with these one size fits all rules and, restrictions, it impacts all of us. And I just think back again, let's go back to the free market. There's plenty of information now online where you can do your own investigation. But, these things are really damaging. And if you're ever called to be on a jury trial, we hope that you take these things into consideration on a product liability lawsuit. All right, so this gets us to our next topic, which you wrote about, and this kind of happened coincidentally. You wrote something about risk calculation, and not too long ago, Vox published an article. I don't know if we have access to that. There's an article on risk calculation. There it is. Plane crashes. Actually, this was a pretty good article explaining the nature of risk. Now, I worked in the television news industry for a long time, and we were constantly ringing the fear alarms on everything. We were always pressured to do stories on like cancer clusters until I learned, a cancer cluster disappears when you start broadening the boundaries of it, right? Because what you're looking at is a very tiny, minuscule segment of the population, and they could be, there could be some relation to them, biological relation to these people, whatever, but it doesn't explain what's going on. But constantly we were, banging the risk drum on everything, and we have risk in everything. What is the most popular activity for many Americans? It's driving a car. Yet what do we read mostly about, and what are we so terrified about? Plane travel, right? So you talk about that.
Oh yeah, it's there was a plane crash in San Diego just a few days ago. It was a private jet, and it made the news. And I have a private pilot's license, so I always, every time I hear about a plane crash, I always perk up and want to read about it, just because. But you think about it, if you look at the average, especially airline travel, it's not quite as safe to fly your own plane because usually pilot error. But air travel is safer than driving a car if you look at miles traveled. Yeah. And if you look at driving a car, about 40,000 people die every year in car accidents. That sounds really extreme, but if you think of out of a country of 330 million people and how many million miles, it is really very, very rare. Mm-hmm. And partly what I wrote about in my article as kind of a case study is over the, within my lifetime of when I began to drive, cars have become much safer. Well, why is that? Well, airbags, seat belts. Cars are designed to crumple on impact. Roads are made safer. Mm-hmm. Trees in the median, trees on the side of the road on a curve have been moved, cut down. And so, the number of, despite population growth over the last 45, 50 years, fewer people are dying on the highways than when I was, a child. It's almost equal. It's like 40,000 versus 50,000 back in the 70s. And it's because it's much safer. And you're like, well, what can we do to make it even safer yet? Well, you don't want it to be safer. Because the way you make it safer is you make us slow down. You make cars much more expensive. You cut back on our personal freedoms. Yeah. And so, if there's a magic bullet to make cars safer, great. But if it involves reducing the speed limit like they did, in the 70s and early 80s, that reduces productivity, that reduces convenience, that reduces, our freedom to travel.
Right. Well, it's always a trade-off. I've written a lot about speed limits, and there are a lot of misconceptions about that as well. People think that slower speed limits are safer, but they aren't necessarily. What it is attention. So if you want to drive fast speeds, you have to be really, really, really alert. Okay. And people overestimate their degree of alertness. They're tired or whatever. So there's no room for error. However, you can cause a fatal injury driving 30 miles an hour. So all of these things, and this gets back to top-down approaches. We saw this so much during COVID. We were recommending all kinds of measures to protect people that made no sense, most namely the vaccine mandates. And, we knew that there was a very small percentage of the population that was at risk from dying from COVID, right? Elderly people, obese people, and those are the ones who probably benefited the most from the shots. But what we ended up doing was foisting these shots on everybody. And actually, they became more dangerous. They put these people in more danger than they needed to be. The same thing with the masks. We got planes and they were making everybody in airplanes wear masks, forgetting the idea that planes have some of the cleanest air around. They have amazing filters. And fortunately, we learned the hard way that they were wrong, and they eventually got rid of the masks. I still see people wearing masks in planes. I don't know why. There's a risk with wearing masks. They carry bacteria, right? It just goes to show you that we just all try to control everything in our lives, and we can't.
Well, the last point that I made in my article was looking back at a 20-something-year-old study by Tammy O. Tings, which looked at cost-saving interventions. This is the data used to regulate, our risk and safety. And what she found, 20-something years ago was that all regulations aren't equal. Some regulations can save a year of life at, $50,000. Other regulations save a life at, $100 million. Why don't we start with the low-hanging fruit before we, enact very costly regulations that do very little good? And that's
Right.
what that means. I mean, if the cost of life here saved is $100 million, that means that's a pretty bad regulation.
Yeah.
And you could do more. You could save more lives by starting with the lower hanging fruit, things like, seat belts,
Right.
airbags, for example.
Yeah. Again, we have information galore now, like we didn't have even 10 years ago. So much information. If you want to do your own analysis of what is dangerous to you, just go ahead and do it. But, the thing about having the government regulate safety is that it takes away our agency, right? We give up. We don't even think about it. We just assume that the government is going to protect us. And that's not really what the government was designed to do. They're there to protect our freedoms and protect our borders, but, protect you from cancer, protect you from, getting too many colds. That's not what we ask the government to do. So, and there's a great line. The thing of it is, we're all trying to control death, right? And illness, pain and suffering. There was a great line I saw not too long ago in the movie Braveheart. And he has this line. He said, look, we all die. The only thing that changes is how and when, right? We can't change the idea that we're going to die at some point. Not taking, don't take stupid risks, but you can't control everything. So just maybe think about that next time you go ballistic over all the stuff you read about how your life is in danger every second. All right. Well, I'll leave it at that. We have run out of time. Be sure to check out healthcare news on the heartland.org website. We'll have a link to that, and the healthcare blog at the Goodman Institute Health Blog. And you can get free market perspectives on the very latest information in healthcare. And in the meanwhile, stay well, stay safe. Thank you for tuning in, and we'll be back in a few weeks.